Good morning, everyone. Today we'll discuss the most important topic, which is cardiac medication. So let's discuss the first question. A client with heart failure is receiving IV furosemide for pulmonary edema. Which assessment finding requires the nurse's immediate intervention? It means the patient is suffering from heart failure. Heart failure is a condition where the heart can't push the blood forward, and the patient is taking furosemide to treat. To treat the heart failure, which finding requires the nurse's immediate intervention? So before solving this question, we need to see what heart failure is. Heart failure is a condition where the heart cannot push the blood out. In this, the heart becomes weak. Due to the heart being weak, instead of the heart normally pushing blood out through the ventricles into the aorta, that is, instead of forward movement, backward movement starts happening within the heart because the ventricle can't push the blood out. Because of this, the blood collects right here. After collecting, it collects in the atria. After collecting in the atria, it collects in the pulmonary vein. Normally what happens is that in this pulmonary vein, blood flows from the lungs toward the heart, but that will keep happening here. Besides that, this blood that was collecting starts moving backward again. Because of this, on one hand, blood is coming from here, and on the other hand, blood is coming from this side. This means that here, these pulmonary veins, there's congestion of blood in them. So this means a condition is created which we call pulmonary congestion. So if there's pulmonary congestion, we are studying the condition of left-sided heart failure because this part is the left side of the heart and this part is the right side of the heart. If there's left-sided heart failure, what will happen? First of all, the patient will have pulmonary congestion. After that, this blood will move even further backward. If it moves backward, then on one side, blood is coming from the pulmonary artery, and on the other side, the blood that had moved backward is coming. Because of all this coming together, the blood pressure will increase here again. And due to the increase in blood pressure, these capillaries in the lungs, I've drawn a diagram of the lungs, the capillaries inside these lungs, an artery comes from here, a vein is here, and there are capillaries between them. There are tiny pores here. So as pulmonary congestion increases, fluid will leak out from here. Now this fluid that leaks out, this fluid inside these lungs, this structure I've drawn, these are the alveoli in the lungs which perform gas exchange. And here, this fluid will arrive. After this fluid arrives here, and this fluid will enter these alveoli. Now, if there's fluid inside these alveoli, meaning water collects, then normally what happens inside these alveoli is that oxygen comes in from here, and this oxygen gas exchange means it will enter the capillaries. And from here, CO2 will come back from this capillary, CO2 will come and enter the alveoli. From the alveoli, CO2 will leave the body, and the oxygen will enter the alveoli, and after entering the alveoli, it will enter the capillary. So because of that, the patient doesn't experience dyspnea. But in heart failure conditions, what happens is that water starts to collect inside these alveoli, meaning fluid collects because the fluid that leaked out of the capillaries fills the alveoli. Due to this fluid collection in the alveoli, gas exchange can no longer occur. Gas exchange won't happen, which means CO2 won't be able to get out from here and oxygen won't be able to get into the blood. This means the blood won't be oxygenated. Because of this, the patient will develop dyspnea. So whenever left-sided heart failure occurs, the patient will have pulmonary congestion and dyspnea. Besides dyspnea, you'll see another symptom. Whenever air flows, and if it flows over this water, if there's fluid here, when air from outside flows through this fluid, a sound is created, and we call that sound a crackle sound. So in left-sided heart failure, there will be crackles, and another name for this crackle is rale. You might see either of these names. Now, besides this, if the pressure in this capillary increases further, RBCs might also leak out. If RBCs leak out, it means the patient will have RBCs here too. If there are RBCs here, what happens? Let's first discuss the condition before RBCs leak out. If, say, this is filled with fluid, then this fluid will go into the bronchus, and as it enters the bronchus and bronchi, the patient will cough. When they cough, what will happen inside? Sputum will form, and it will be frothy because as they cough, froth will form in this fluid along with the air. Since froth forms when the patient coughs, there will be frothy sputum, so frothy sputum is also a symptom of left-sided heart failure. Additionally, in this patient, if the pressure here increases significantly, RBCs will also leak out from the capillary. If RBCs leak out, it means that here, in the alveoli and the lungs, there will be RBCs. Since there are RBCs, the froth forming here will be red in color because of them. This means red frothy sputum will form. So these are also symptoms of left-sided heart failure. So what will be the characteristics of left-sided heart failure symptoms? First, there will be pulmonary congestion. Besides that, the patient will have dyspnea, shortness of breath will be observed, and the patient will have a frothy cough, and it could even be a red frothy cough. Another characteristic is observed, which is paroxysmal. It's paroxysmal nocturnal dyspnea. So paroxysmal nocturnal dyspnea is also seen in this. Paroxysmal means suddenly, nocturnal means at night, and dyspnea means dyspnea, or difficulty breathing. This happens because when a patient is standing or sitting, blood collects in their legs, but as soon as the patient lies down, the blood from the legs reaches the heart. Once it reaches the heart is unable to push this blood forward, so it moves backward and enters the lungs. So as soon as the patient lies down, more blood reaches the heart. It reaches the lungs more. This means the patient suddenly develops dyspnea, but as soon as the patient stands back up or sits down, meaning he sits back down or stands up, then that fluid goes back towards the legs. The fluid that was coming stops flowing. It becomes very little, which means he gets relief in breathing. This happens suddenly. So for suddenly, we use a word that we call paroxysmal. It happens especially at night because the patient sleeps at night. So then nocturnal and difficulty in breathing. So this means paroxysmal nocturnal dyspnea is also seen in left-sided heart failure. If the patient has right-sided heart failure, meaning there's failure on the right side, then normally what happens is that the right ventricle sends blood into the pulmonary trunk, after which the pulmonary arteries go to both lungs to oxygenate the blood. But if the right ventricle cannot push the blood, so the blood will go back into the right atrium, and after entering the right atrium, it will move backwards. On the upper side, on the upper side is the superior vena cava, and on this side is the inferior vena cava. So this blood will move backwards into the superior vena cava. Connected to the superior vena cava is the jugular vein, so this vein will become distended. This means in right-sided heart failure, we will see a distended jugular vein. Normally, blood comes into the inferior vena cava from this side, so that blood is already coming in. But in addition to that, this blood will move backwards. This means the blood pressure inside it will increase. Now, if this pressure continues to increase within the inferior vena cava, it means that here in the inferior vena cava, where blood also enters from the liver through a vein, normally blood should flow from the liver into this inferior vena cava, and it was doing that, but because of the backward movement from the heart, that blood also causes the pressure here to increase significantly. If the pressure increases significantly, it means that since there are capillaries in the liver, the fluid will shift from here, fluid will enter it, fluid will accumulate within the liver tissues. If fluid accumulates in the liver tissue, it means the size of the liver will increase, so we can call it hepatomegaly. We use the word hepato for the liver, and megaly means becoming large. So this was the second symptom. The first symptom of right-sided heart failure was the distension of the jugular vein, and the second is developing hepatomegaly. And when hepatomegaly occurs in a patient, it means the hepatocytes, or rather the liver cells, can't function properly. One of the functions of liver cells is to produce proteins, specifically the production of albumin protein. The role of albumin protein is to maintain oncotic pressure. If albumin protein levels drop, there won't be enough oncotic pressure. It maintains the fluid inside the blood vessels, which means it prevents fluid from leaking out of the blood vessels. But if albumin is absent, it means there will be a change in oncotic pressure. Oncotic pressure will decrease. Fluid starts moving out of the capillaries. If fluid starts moving out of the capillaries, then from the capillaries inside our abdomen, fluid will start coming out. So inside our peritoneal cavity, fluid will collect, which we call ascites. This means in right-sided heart failure, the next symptom will be ascites. Besides ascites, we can say that when and suppose if fluid leaks out from this vein, if it leaks out, it means it will enter the tissues. So we call this edema. So this will be peripheral edema. These were the characteristics of right-sided heart failure. So now, the main thing we saw here was, what is the main problem in heart failure? Fluid retention is happening inside the body. So now what do we need to do? We need to give the patient a medication that prevents fluid retention. So the fluid is expelled so that fluid doesn't collect in the patient's lungs. For that, we have given the patient furosemide. Any medication that ends with ID, all those medications are loop diuretics, like furosemide, torsemide, all these medications are loop diuretics. Now, loop diuretic means that in our kidney, there are many nephrons, and these loop diuretics enter the nephron and act on the loop of Henle. So inside the nephron, the loop of Henle is this part. It acts here too, on this part. Now inside this loop of Henle, there are some channels here which we call sodium, potassium, and chloride channels. There are sodium, potassium, chloride channels. Now we must remember here that through these channels, normally when sodium goes in, potassium goes in. If sodium doesn't go in, potassium won't go in. But besides these channels, what happens elsewhere in the body? Both work opposite to each other. If sodium goes in, potassium goes out. If we later, when we study the drug spironolactone, then in that, what are they? There are principal cells here through which exchange occurs. So in them, what will happen? That if sodium goes in, potassium will come out. If sodium doesn't go in, potassium won't come out. They both work opposite to each other. But in this one, the sodium-potassium chloride channels inside the loop of Henle, what will happen in that? If sodium goes in, potassium will go in. Okay, if sodium doesn't go in, potassium won't go in. So whenever we give the patient a loop diuretic or furosemide or torsemide, then that loop diuretic will come and block this channel, meaning it will block the sodium-potassium chloride channel. Now, if this channel is blocked, it means that our filtrate that was coming, meaning the urine that started forming here, which we call filtrate, this filtrate, whatever sodium is in this filtrate, that sodium can no longer be reabsorbed and enter these blood vessels. This means that the sodium will now be excreted from the body. And that's exactly what we wanted. That's our purpose. Because when sodium leaves the body, water will also leave along with the sodium through osmosis. So water will be excreted. And that's what we want in heart failure, for any extra water in the body to be removed. Now, when the extra water leaves the body, one of our goals was that the extra fluid collecting in our body due to heart failure would be eliminated. So that's done. But along with this, we saw that besides sodium, the potassium that normally should have come inside, that potassium can no longer come inside. If potassium doesn't come inside, it means potassium will also be excreted from the body through urine. So potassium will also be lost. This means we can say that loop diuretics are potassium-wasting diuretics, meaning they are drugs that excrete potassium. So when they waste potassium or excrete potassium, it means that for the patient, we need to provide a potassium-rich diet. For example, we will now give the patient potatoes, tomatoes, coconut water, spinach, and we can also give avocado or bananas. So a potassium-rich diet must be given whenever a patient is on furosemide, and we must also keep checking the potassium level because there's a chance of the patient developing hypokalemia. Furthermore, especially and mostly when a patient has heart failure, we can also give the patient digoxin in that condition. So whenever digoxin is given, if we've given potassium with it, it's possible that if potassium is excreted, there's a chance of digoxin toxicity due to hypokalemia. So that's why whenever we give furosemide or a loop diuretic, we must provide a potassium-rich diet to the patient. And there's one more thing you need to keep in mind regarding potassium. Whenever a potassium infusion is done or a potassium injection is given, we must give the potassium injection slowly. If we don't give it slowly, then our ear, meaning this ear here, has an internal ear inside it, and there's a structure in there called the cochlea. This is responsible for hearing. Besides this, it contains these semicircular canals that work to maintain balance. But this cochlea, which handles hearing, has hair cells on it. These tiny hair cells, if we give loop diuretics rapidly, meaning if we give furosemide too fast, it starts damaging these hair cells, which can lead to permanent hearing damage or hearing loss. But in the initial stages, if, say, we gave furosemide to the patient too fast, or if we gave more than the required dose, then the patient develops tinnitus, meaning they start hearing ringing in their ears. So as soon as the patient gets tinnitus, it means we need to slow down the speed of furosemide or give it slowly or adjust the dose. So furosemide's an ototoxic drug. So now let's move on to our question and see what the question's asking. So the patient has heart failure and is given furosemide. Now, what will be the nurse's immediate intervention? Which of these is a serious problem? A potassium level of 3.1 milliequivalents per liter. The normal potassium level is 3.5 to 5 milliequivalents per liter. This means this is it's below normal, which means there's a chance of hypokalemia. And whenever a patient has hypokalemia, it can cause cardiac dysrhythmia in the patient. This means this condition is always serious, so here, the correct answer will be this: increased urine output of 2. Increased urine output of 2,400 milliliters per day. Urine output is increased. This is exactly what we expect. This is what we want to happen so that excess fluid is removed. This is expected. A blood pressure of 102 over 60 millimeters of mercury is normal, and the diastolic is a bit low, but it's fine. But whenever we give a patient a diuretic, the blood pressure can drop slightly, causing mild hypotension. Reports of increased thirst and dry mouth. This is also expected. A client with lisinopril has been taking the medication for 5 days. Lisinopril. Whenever you see pril at the end of a medication, understand that it's an ACE inhibitor. That's the drug class. ACE inhibitor. Which assessment finding requires the nurse's immediate intervention? Which of these assessments would require the nurse to intervene immediately? This means we need to choose the most serious condition from these. Before solving this question, we need to see what lisinopril is. Any drug, that is, if you see pril at the end of any drug, understand that it's an ACE inhibitor. So whenever you see an ACE inhibitor, you have to remember that its side effects can mostly be derived from ACE itself. ACE. Whenever you see pril, understand it's an ACE inhibitor. Since it's an ACE inhibitor, you should derive its side effects from ACE. A for angioedema, angioedema. C for cough. And E for elevated. Potassium. Now from here, we need to see what angioedema is. Angio means blood vessels. Blood vessels meaning it's related to capillaries, so the capillaries will dilate in this, and edema means the swelling that occurs because the capillaries dilate is what we call angioedema, and it's mostly seen around the lip, seen around the tongue, and seen around the throat. Whenever this happens, if you see that the lip have edema, or if there's edema in the tongue, or if the patient is having difficulty swallowing because of the edema, then understand that this edema could also occur around the trachea. This means there's a higher chance of airway obstruction in the patient, so this is its most serious complication. Cough is also a complication, but it doesn't usually cause any immediate harm to the patient, so a cough is an expected side effect. And potassium is also elevated, but among these, the most serious condition is angioedema. So now let's solve this question. A dry, persistent cough that worsens at night. Yes, this is expected in the patient, but it doesn't require immediate intervention. A blood pressure of 104 over 68 millimeters of mercury. This is expected, a little bit lower, but lisinopril is an antihypertensive drug, which is why a bit of mild hypotension is expected with it. Swelling of the lips and difficulty in swallowing. As soon as swelling of the lips and difficulty in swallowing occurs, you must understand that angioedema has developed in the patient. Angioedema means there were chances of airway obstruction. This is the most serious condition, and you need to stop the medication and inform the doctor. So this will be our answer. Potassium level of 5.2 milliequivalents. Potassium level of 5.2 milliequivalents. This is also a bit, above normal. The normal level is 3.5 to 5 milliequivalents. This means it's slightly elevated, but compared to this, we must prioritize the airway because this is mostly a trap. Students see the increased potassium and think it affects the heart, so they pick that. But don't do that. We must apply the ABC rule here. Airway, breathing, circulation. Prioritize the airway first. If you do that, we must choose swelling of the lips and difficulty in swallowing. You should get the idea that this happens because of angioedema. Normally, now we need to see what ACE inhibitors are and how they work. Examples of ACE inhibitors include lisinopril, captopril, enalapril, and ramipril. Now, normally, these work on the RAS system, RAAS. They lower blood pressure by working on the RAS system. This is the renin-angiotensin-aldosterone system. What happens is that normally our body secretes a protein which we call angiotensinogen. This is in everyone's body. But as soon as the BP drops, if let's say the blood pressure drops, the kidney secretes renin. When the kidney secretes renin, this angiotensinogen gets converted into angiotensin 1. In angiotensin 1, you can get an idea from the name. Angio means blood vessels, tensin means to constrict. But it can't actually do that. This means we can call it an inactive form. It'll be in an inactive form. This means whenever there is angiotensin 1, it won't be able to constrict the blood vessels. But as it moves forward, this blood reaches the lungs, and the lung secretes ACE, ACE. From E, E stands for enzyme, an enzyme that converts angiotensin 1 into angiotensin 2. That's why its name is ACE. Enzyme that converts angiotensin 1 to angiotensin 2. So now this becomes angiotensin 2. As soon as it converts into angiotensin II, this angiotensin works according to its name. Angio means blood vessels, and tensin means to constrict. Now it will constrict them. This angiotensin will now reach inside the blood vessels. And in these blood vessels, you can see these small marks I've made. These are angiotensin receptors. You need to remember these because when we study angiotensin receptor blocker medications, they will work right here. If you've understood this, it means you can also understand the next category of questions, which are the angiotensin receptor blockers, where you've probably seen sartans like losartan or telmisartan. These medications work right here, but we'll discuss those in the next question. Right now, we're discussing how once angiotensin II is formed in the body, it moves forward, and there are certain receptors in the blood vessels. These receptors are made for angiotensin, which means we call them angiotensin II receptors. The same receptors are also found here on this gland above our kidney. This is our kidney, and on top of it is a suprarenal gland. And in this suprarenal gland, there are also small receptors like these that attach angiotensin II to themselves. Now, as soon as angiotensin II arrives here, that angiotensin II will bind with it right here. It will bind. Now it will work just like its name. Working like its name means angio means blood vessels and tensin means to constrict. It will now constrict it. And if it constricts, what will happen? As soon as the blood vessels constrict, the blood pressure will increase, because we know the formula for blood pressure is systemic vascular resistance multiplied by heart rate multiplied by cardiac output. If systemic vascular resistance increases, it means blood pressure will increase. This is the normal RAS system, which works whenever there is hypotension. Besides this, normally what happens is that as soon as angiotensin II is in our body, it will move forward and attach to these receptors. Because of this attachment, it will be secreted here. Aldosterone, and that aldosterone will come here into the kidney, into the nephron, and in the nephron it will increase the reabsorption of sodium, and if it increases sodium reabsorption, sodium in the blood will increase. If sodium increases, then along with sodium, water will also increase. Water reabsorption will increase. If water reabsorption increases, it means fluid will increase. If fluid increases, it means blood pressure will increase. So this is the normal condition, but when a patient has hypertension, why do we give them angiotensin ACE inhibitors? Meaning these two events that were happening, one where sodium was increasing because of aldosterone, and this one where BP is increasing because of it, meaning the blood vessels are constricting. To stop both of these things, we will give some medication so that these two events don't happen. If these two incidents don't occur, the blood pressure will decrease. We need to dilate the blood vessels and stop the sodium here. If we stop the sodium, then water and sodium won't go into the blood, they will be excreted. So, meaning, now we will give some medication. Now we saw that the angiotensin 1 here was not causing these two events. Neither was renin causing these two, nor was angiotensinogen causing these two. Why not? Now, where did the events start? They started because of angiotensin 2. So why don't we give a medication that stops this angiotensin 2 from being formed? For that, we'll have to give this. Which means for this, we'll have to stop this ACE inhibitor enzyme. This ACE enzyme. So angiotensin converting enzyme, meaning we'll give medication to stop this enzyme. So now we have given the patient ACE. Inhibitor. Inhibitor, as the name suggests, it will inhibit what? ACE. This means when we have given the patient pril medications, that is, all such medications that end in pril, like lisinopril, captopril, ramipril, enalapril. By giving all these, they will inhibit the production of ACE. If ACE is not formed, it means angiotensin 2 will also not be formed. If 2 is not formed, it means angiotensin 2 will not come here, and 2 will not come. This means there will be no constriction of blood vessels, This means systemic vascular resistance will decrease, and whenever systemic vascular resistance decreases, blood pressure will decrease. Besides this, if we don't have angiotensin 2, aldosterone will not be formed. And if aldosterone is not formed, then here in our kidney, inside this nephron, sodium absorption will not occur. And if sodium absorption does not occur, then sodium will go out and sodium will be excreted. Along with it, water will be excreted, which means there will also be a lack of fluid, so it means BP will decrease. So this was how pril medications or how ACE inhibitors work. So this was their mechanism of action, but we saw why hyperkalemia occurs in the patient. So what happens in the DCT and collecting duct is that it comes and blocks the principal cell. And if it blocks the principal cell, then sodium won't be able to go in. And if sodium can't go in, it means potassium won't come out. Here, both are opposites. If sodium goes in, then potassium will come out. If sodium doesn't go in, then potassium won't go out. Okay, so this means these blood capillaries we have here. So these blood capillaries, there is potassium in these blood capillaries, but now the sodium that was there is going straight out from here. If sodium had entered these blood capillaries, then potassium would have gone out. But now what happened is that sodium didn't come in, so potassium won't go out from here. This means potassium will stay in the blood. So there are chances of hyperkalemia occurring in this patient. So whenever we give a patient an ACE inhibitor, there will be chances of hyperkalemia. This means you must remember that whenever giving an ACE inhibitor, do not give the patient salt substitutes. Because when you give a patient salt substitutes, they contain a lot of potassium. Besides this, we've seen that the potassium level in the patient will increase, sodium will be excreted, meaning sodium won't return to the blood. If it doesn't return to the blood, it means potassium won't leave the blood. If it doesn't leave, it means there are chances of hyperkalemia, but this is mild hyperkalemia. Additionally, there will be swelling of the lips, and difficulty swallowing. Why does this happen? Let's see. First, let's look at why a dry, persistent cough that worsens at night happens. This happens because inside our body, in the blood, there's one more thing, which we call, let's say these are blood capillaries, blood vessels. So inside this blood, there's an inflammatory mediator, which we call bradykinin. This bradykinin is an inflammatory mediator, meaning wherever it goes, it causes inflammation, which means it causes vasodilation. This bradykinin keeps circulating in the blood, but as it goes into the blood, now ACE will be formed here. This ACE keeps destroying this bradykinin. It'll break down the extra bradykinin. That is, it'll destroy it. So it will destroy it, meaning it won't have an excessive effect. But if we've given the patient an ACE inhibitor, then ACE production won't happen. So angiotensin converting enzyme production won't happen. This means now there's nothing to break down the bradykinin. So now wherever you look, you'll see bradykinin, meaning bradykinin, its level will increase. Now this bradykinin starts going into the lungs, and after entering the lungs, there are some receptors in the lungs that we call cough receptors. Bradykinin irritates these cough receptors, and because of this irritation, the patient develops a dry cough. So this is a side effect for the patient when an ACE inhibitor is given. Apart from this, when bradykinin is present, what happens in that patient is that there will be excessive bradykinin, which causes dilation of the capillaries. So if we look at the patient's capillaries, let's say these capillaries here. When more bradykinin reaches here, the diameter of these capillaries will increase. If the diameter increases, fluid will leak out, which means it will enter the surrounding tissue, causing edema, which we call angioedema. This means the edema occurring is due to these capillaries. The word used for capillaries is angio, so it's called angioedema. So all of this is done by your... But we have an alternative. Suppose we want to lower the patient's blood pressure by working on the RAAS system, but the patient is coughing a lot, meaning they have a severe dry cough and a lot of discomfort. Then we have an alternative, which is, why not let this ACE form? Because if ACE is formed, bradykinin will be broken down. It'll be destroyed. This means there's no chance of angioedema in the patient, and besides that, there won't be a dry cough either. So why not let this ACE form? This means we won't give an ACE inhibitor. But if ACE is forming in the body, it will convert angiotensin 1 into angiotensin 2. So angiotensin 2 will be produced. But as soon as angiotensin 2 is formed, we saw that blood pressure will rise, and sodium reabsorption will increase because it boosts aldosterone secretion. So what do we do now? What will we do for a hypertensive patient? We can't stop ACE, and angiotensin 1 will automatically change as soon as ACE is present here. Now that angiotensin 2 is formed, why not do something so that the patient's blood pressure is lowered, but angiotensin remains as it is? What we'll do is give the patient medication that blocks these receptors from the front. Since it blocks these receptors, it will be called a blocker. It's blocking, so they're called blockers. And what are they blocking? Receptors. So the name becomes receptor blocker. And which receptors are they blocking? Angiotensin. So it's angiotensin, and they're blocking the type 2 receptors, right? They're angiotensin 2 receptors. So it's angiotensin 2 receptor blockers. So the name will be, we take R from here, B from here, and add an S because there are multiple drugs, so it's S. So these drugs are called ARBs, ARBs, which means angiotensin receptor blockers. Now, if they've blocked this, it means no matter how much angiotensin 2 circulates in the body, its receptors are blocked. Since they're blocked, it won't be able to affect the blood vessels, because if the receptors themselves are blocked, it means it won't be able to constrict the blood vessels here. Similarly, what happens here is when we give ARB medications, meaning angiotensin 2 angiotensin receptor blockers, which mostly end in sartan. So this sartan suffix belongs to all ARBs, or angiotensin receptor blockers, like losartan, valsartan, telmisartan. So when the patient is given this drug, just as it blocked there, it will also block the receptors on the gland above our kidney, which we call the suprarenal gland. There are receptors here too, and it will block these receptors as well. Now that it has blocked these receptors, the angiotensin 2 that was circulating won't be able to come and stimulate these receptors. If it doesn't, then aldosterone won't be produced. Aldosterone won't be formed. If aldosterone isn't produced, then normally, what does aldosterone do? It increases sodium reabsorption, meaning it worked to bring sodium from the nephron tubules back into the blood. Now what will happen in this case? Now, aldosterone hasn't been produced at all. If aldosterone isn't produced, then what will happen? If aldosterone isn't produced, it means sodium reabsorption won't occur. Sodium will be excreted, and along with sodium, water will also be excreted. This means our goal of removing sodium has been achieved, and the goal of lowering blood pressure has also been met. Plus, angiotensin 2 remains in the body, and ACE continues to be produced, so the patient doesn't get angioedema or the discomfort of a dry cough. So we'll discuss that in the next question. A client with a history of systolic heart failure is prescribed a calcium channel blocker. Which medication order should the nurse question immediately? This means the patient has heart failure. Because of heart failure, they've been prescribed a calcium channel blocker. But which medication order should the nurse question immediately? This means all these listed medications are calcium channel blockers. But which one of them can't be given in heart failure, leading the nurse to question why this medication was prescribed? So if they are all calcium channel blockers, how will you figure out which one shouldn't be given? So for this, let me give you a brief introduction to what calcium channel blockers are and how they work. Now, let's talk about a normal situation. This is our heart, and these are the blood vessels. Inside this heart, this is the SA node, this is the AV node, and here is the myocardium of the ventricles. In this SA node, there's a channel built in. Through this channel, calcium can enter, so we call it a calcium channel. Similarly, the AV node also has a channel on it, which we call a calcium channel. And just like that, there are many calcium channels on the myocardium of this ventricle as well. Normally, calcium is necessary for our smooth muscle contraction. If calcium enters the smooth muscles, then smooth muscles will constrict. If it doesn't, then they won't constrict. So here, if calcium enters the SA node, then the SA node will be able to generate more beats. It'll fire more and generate a higher heart rate. If it enters here, the AV node's job is conduction. If calcium enters here, then all the impulses or electrical signals from here will be transmitted downwards. This means they facilitate conduction. And these calcium channels here, which are on the myocardium of the ventricle, if calcium enters these, it will constrict easily. The muscles here will constrict well. This means the ventricle will be able to contract forcefully. But we've given the patient medication that will block these. Since it blocks them, they're called blockers. So this is a blocker. And what are they blocking? They're blocking the channel. And which channel? The calcium one. So this is a calcium channel blocker. Now, these calcium channel blockers we have come in two types. One type works on the heart, and the situation I described also occurs in blood vessels. Blood vessels, especially in the artery, and the artery also has smooth muscles. Contraction in smooth muscles only happens when calcium enters through these calcium channels, meaning that's when it constricts. If calcium can't constrict inside, it means It won't be able to enter. This means the blood vessels won't be able to constrict. If they don't constrict, they'll stay dilated and relaxed. The medications that block these channels are also called calcium channel blockers. Now, among the calcium channel blockers we have, there are two types. Some have dipine at the end. All these calcium channel blockers we have end in dipine, like amlodipine, nimodipine, nifedipine, nicardipine. This means whenever you see a drug ending in dipine, you should know it's a calcium channel blocker. But one thing you have to remember is that any drug ending in dipine works on the arteries. They don't work on the heart. They'll work on the arteries, meaning they block the calcium channels within the artery. As soon as they block them, calcium can't get inside. If calcium can't get in, then constriction can't happen. No constriction means the smooth muscles will relax. So these, as well, what will they do? They'll dilate the arteries. They'll cause dilation of the artery. They dilate, so blood pressure will automatically drop. But you have to remember one thing, that sometimes you'll see two names. One is dihydropyridine, calcium channel blocker, and non-dihydropyridine calcium channel. What happens is, in the chemical composition of these dipine medications, there's a ring like this, and this ring is what we call a pyridine ring. This means it becomes, so it has a pyridine ring, which is why we call it pyridine, and here two hydrogens are attached, H and H for hydrogen. Its structure is like this, and since there are two, we use the word di, and for hydrogen, it's hydro. Dihydropyridine. This means it's a dihydropyridine CCB. So calcium channel blockers that have a dihydropyridine ring work on the blood vessels, and all of them end in dipine. Besides these, meaning apart from these dipine calcium channel blockers, any other calcium channel blockers are called non-diet, hydro, pyridine, CCB, meaning calcium channel blocker. In this category, we have diltiazem and verapamil. So you must remember this to solve this question. Diltiazem and verapamil work on the heart. Now, when they work here, what happens is they'll block the calcium channels. If they block the calcium channels, it means they'll decrease the heart rate. If calcium entry into the SA node decreases, the speed of heart rate generation will slow down. This means they will reduce the heart rate, and if the heart rate decreases, it means they are negative chronotropic. We measure heart rate in time, and another word for time is chrono. And for decreasing, we use negative. And tropic means an action occurring. So this means all calcium channel blockers will be, and the word for time is chrono. Isn't it like chronology? Anyway, chrono and then an action occurring, any incident occurring, we call that tropic. So this becomes negative chronotropic because it reduces the heart rate. Besides this, if it stops calcium entry into the AV node as well, because once we block the calcium channel, it's blocked, this means the AV node's function will also decrease, and the AV node's job is to send impulses from the atria down. If it can't send them down, it means no conduction. If there's no conduction, it will also reduce conduction. So if conduction stops from here, it also reduces conduction, and the word we use for conduction is dromo, and it reduces it, which means negative, and an action is happening, which means tropic. So this means it is negative dromotropic. In addition to this, if the calcium channels in our ventricular myocardium are blocked, the calcium channels that were there when we gave the CCB, because of that blockage, it won't be able to constrict properly. It won't be able to constrict, which means the force of constriction will be reduced. This means it reduces contractility. And for contractility, so it reduces contractility. Contraction, melasticity. This means it will reduce the force That is, it will reduce the force of contraction. And the word we use for force is eno. It reduces it, so we'll call it negative and eno. And it performs an action, so tropic. So we can say that our calcium channel blockers, especially those that work on the heart, are negative chronotropic because they reduce the heart rate. They are negative dromotropic because they reduce conduction through the SA node, and then negative inotropic because they reduce the force of contraction of the ventricle, that is, contractility. You have to remember which one works on the heart and which one works on the arteries. Besides this, you should also keep in mind that our intestine has smooth muscles, and only when there's contraction in the smooth muscles does peristaltic movement occur. Whenever we give verapamil to a patient, mostly this verapamil has another side effect called constipation. This is because it also blocks the calcium channels in the smooth muscles of our intestine. And because the calcium channels are blocked, calcium cannot enter the smooth muscles of the intestine there. As a result, peristalsis decreases, so there are chances of the patient developing constipation. So that was a brief introduction to calcium channel blockers. Now let's solve this question. That is, the patient has heart failure. Heart failure means blood is not being pushed out. Blood is not being pushed out, which means blood is staying here and moving backwards, meaning the force within the heart has decreased. The heart has become weak and cannot push properly. The ventricles cannot contract well. So now we have to see which of these calcium channel blockers we cannot give, while all others can be given. So amlodipine. Now, for whichever one ends in dipine, you can see from that it reduces blood pressure. If in the rest of the body ahead, if blood pressure is high, the heart has to work harder against that pressure, which is not good. So we need to give medication that dilates the blood vessels, specifically the arteries. This allows the heart to pump more easily, and the blood flows out better when the pressure is lower. So this means the dipine medications, as we saw, they dilate the blood vessels, which means they reduce systemic vascular resistance. Because of that, we can prescribe them in cases of heart failure. So that means all these dipine medications, look at all of these, we can actually give them. But the question asks, which one should we not give? So that means we're going to eliminate these three right here. Dipazine is here, so eliminate this one, and eliminate this one. What's left? Diltiazem. Now, why can't we give diltiazem in this case? Well, normally what happens, if you haven't studied calcium channel blockers by dividing them into two categories, you'll either get this question wrong or you'll end up skipping it. I guarantee it 100%, because otherwise you'd think they're all just calcium channel blockers. So how do you decide which one to avoid? That's why you have to divide calcium channel blockers into two categories. One works on the heart and the other works on the blood vessels. The ones that work on blood vessels are the dipines, and they won't have an effect on this. This means that normally when we give a patient diltiazem or verapamil, what's going to happen? Well, we saw what diltiazem and verapamil actually do. They'll reduce the force of contraction here. They'll decrease it. This means in heart failure, the force of contraction is already low, and if we give diltiazem or verapamil, that force of contraction will drop even further. And if it's lower, it means the blood won't be pushed out effectively. The heart was already weak, and we've made it even weaker. This means the heart failure condition will get much worse. So you need to keep in mind that this answer is the correct one, meaning cannot give diltiazem to a patient if they're suffering from heart failure. A client with hypertension is prescribed losartan. Sartan, whenever a drug ends in sartan, you should know it's an ARB. These are ARB medications, meaning angiotensin II receptor blockers, which we discussed in the previous question. After developing a severe cough while taking an ACE inhibitor. See, this is what we discussed in the previous question, that when a patient is given an ACE inhibitor, then in that patient, ACE isn't produced. If ACE isn't produced, it means that to break down bradykinin, there won't be anything, so bradykinin will accumulate in the body. The more bradykinin there is, the more it moves into the lungs, and as soon as it enters the lungs, it irritates the cough receptors there. This irritation means the patient will develop a dry cough. This causes discomfort for the patient, so as an alternative, we use ARBs, meaning we use the sartan medications. So this is what's given to the patient. Which statement by the client requires the nurse's immediate follow-up? Immediate follow-up means we need to identify the incorrect statement. My dry cough is much better now. Yes, the patient was previously taking an ACE inhibitor, and the primary side effect of an ACE inhibitor is a cough. So if that's discontinued and we've started ARBs instead, it means the hypertension will be managed and the patient's dry cough will also resolve. So this is a correct statement, but we're looking for the incorrect one. I will use salt substitutes on my food every day. Salt substitutes. Now, some students think that these salt substitutes must contain sodium, but that's not actually the case. Salt substitutes don't contain sodium, but they do contain potassium. Now, as we've seen with all ACE inhibitors, or ARBs, meaning all the Pril medications and all the sartan medications, within those, what happens is that sodium is excreted from the body, but potassium is retained. We saw this earlier, right? We discussed it in the previous slide. It's because they act on the RAS system, the renin-angiotensin-aldosterone system. So aldosterone won't be produced. If aldosterone isn't produced, sodium reabsorption won't occur, and sodium will leave the body. When it leaves, water follows. But sodium and potassium both work in opposite ways. Their entry mechanisms are opposite. In the DCT and PCT of our nephrons, if sodium is excreted from the body, it means potassium stays in the body. Sodium in the blood vessels didn't enter. Sodium didn't enter the blood vessels. This means potassium didn't move from the blood vessels into the kidney tubules, the DCT or the collecting duct, and if it didn't go there, the potassium stayed in the blood vessels. And if potassium stays in the blood vessels, the patient is at risk for hyperkalemia. So whenever we give a patient an ACE inhibitor or an ARB, whether the drug ends in Pril or sartan, you must understand that potassium retention will occur in that patient, leading to a risk of hyperkalemia. Therefore, we must avoid food items containing potassium. Since salt substitutes contain potassium, this is an incorrect statement, making it our answer here. I sometimes feel dizzy when standing quickly. Dizziness occurs because ACE inhibitors and ARBs promote water excretion, which lowers blood pressure. They also cause vasodilation, further lowering it. So when a patient stands up, like moving from lying to sitting or sitting to standing, gravity causes the blood to pool downward. It's pulled down, meaning less blood returns to the heart. With less blood at the heart, when it pumps, less blood reaches the brain. Reduced blood flow to the brain means decreased cerebral perfusion, which causes the patient's dizziness. So this is also a correct statement. I take the medication at the same time each morning. It's good to take medication at the same time daily. Taking it in the morning is also ideal because as sodium is excreted, water follows. Since these medications increase urination, they should mostly be given in the morning to avoid disturbing the patient's sleep at night. A client with asthma and hypertension is prescribed propranolol. Any medication ending in lol is a beta blocker. It's given to lower the patient's hypertension, but the patient also has asthma. This is crucial. We must keep the asthma in mind when selecting the answer. Which assessment finding requires the nurse's immediate intervention? For which of these findings would the nurse need to intervene immediately? So, a heart rate of 58 beats per minute. The heart rate is low in this case. That's not a good sign either, but next is a blood pressure of 102. If it's being given to lower hypertension, then this blood pressure is expected, so we can eliminate that option. After that is expiratory wheezing and shortness of breath. Yes, that's also a bit of a warning sign, so we'll have to choose between those two. Then there's the report of fatigue during exercise. Now, whenever we give a patient propranolol, what it does is, in our system, it slightly reduces our sympathetic stimulation. Without sympathetic stimulation, the patient has less energy and might feel fatigued. That's expected. We need the unexpected. Now we choose between these two, the heart rate or the wheezing and shortness of breath. We'll apply the airway, breathing, and circulation rule here. We'll prioritize the airway, so we eliminate the heart rate option. That leaves us with expiratory wheezing and shortness of breath. So this will be the correct answer. But why does this happen? To understand that, we first need to look at what beta blockers actually are. So they are blockers. These are blockers, which means they'll block things, and beta means they'll block the beta receptors. In our body, beta receptors, this is our heart, and these are the lungs. There are beta receptors in two places. The receptors in the heart are called beta-1 receptors, and the ones in the lungs are called beta-2 receptors. You can remember it this way. we have one heart in our body, so those are beta 1 receptors, and we have 2 lungs, which means we call the receptors found in the lungs beta 2 receptors. Now, normally, when the beta 2 receptors in our lungs are stimulated, it causes the smooth muscles of the bronchi and bronchioles to relax. And if those smooth muscles relax, it means the bronchi and bronchioles will dilate. They'll dilate, meaning the airway opens up, which is a good thing. But if they aren't stimulated and they get blocked instead, then the opposite effect occurs. So whenever we give a patient a beta blocker, the opposite of the normal process will happen. Beta receptors are also found in the heart, specifically the beta 1 type. There are receptors on the SA node, and there are receptors on the AV node as well. In addition to those, there are also receptors on the walls of the ventricles, which will be beta receptors. Now, whenever there's sympathetic stimulation or a stressful situation, these receptors get stimulated. When they're stimulated, they increase the activity of the SA node, which in turn increases the heart rate. These receptors are also found on the AV node. The AV node's job is to transmit or conduct impulses from the atria down to the ventricles. So when these receptors are stimulated, that's exactly what happens. And similarly, these receptors, the beta receptors, are located on the myocardium. So when they're stimulated, the myocardium can contract effectively. But if we give the patient a beta blocker, it means these receptors are now blocked. Now, if we've given the patient beta blockers, then these receptors won't be able to be stimulated. The receptors here at the AV node won't be stimulated either, and the beta 1 receptors on our myocardium won't be stimulated either. So this means we've given the patient a LOL medication. That is, for all drugs, if they end in LOL, then we can say that these are beta blocker drugs. For example, if I write the whole list here, for instance, if I write the entire list out for you, under LOL we have atenolol. Besides those, we have a few others, which are... So all these drugs ending in LOL are what we call beta blockers. Now, what do? We need to keep two things in mind. All these drugs from here to here, like atenolol, esmolol, bisoprolol, metoprolol, and labetalol, they act only on the heart. This means they'll work only on the heart. And which receptors are in the heart? They're beta 1 receptors. So that means they'll only reduce the heart rate. They'll lower the heart rate, decrease cardiac output, and they'll also reduce conduction. So these don't act on the lungs. This means when a patient has lung issues like COPD or asthma, we can give this medication if we need to lower their hypertension. Suppose a patient has hypertension and we need to reduce it, we can give this medication. Even if the patient has asthma, we can give it because it doesn't affect the lungs at all. It only acts on the heart. So that means it's safe. Therefore, they'll be safer for COPD and asthma patients. So they'll be safe for patients with asthma and COPD. This means we can say these drugs are specific only to the heart. This means that for specific, we use the word selective. And for the heart, we use the word cardio. So these beta blockers will be cardioselective beta blockers. Beta blockers. So you must remember this category to solve this question properly. This means you need to know the names of these drugs. You'll have to memorize these. These drugs only work on the heart, so they're called cardioselective beta blockers. They're safe for patients with COPD and asthma because they don't cause bronchospasms, as they don't affect the lungs at all. Besides those, the remaining medications like propranolol, timolol, and sotalol, what they do is they work on both. These drugs will act on both the heart and the lungs. This means these medications that work on both, these ones right here, since they work on both, it means they aren't specific to either. For not, we use the word non, and for specific, we use selective. So these are non-selective beta blockers. This means they'll work on the heart and also on the lungs. On the heart, they'll work to decrease the heart rate and also lower the BP. This means if we give these to a patient with hypertension, they'll work. Additionally, when they act on the lungs, what happens is they'll block our beta receptors. By blocking them, it means these beta receptors won't be stimulated. And if they aren't stimulated, it means the smooth muscles won't dilate. Instead, they'll constrict. Constriction means they'll narrow. Narrowing means that for patients with asthma or COPD, it will cause even more problems. So this means these drugs, what they'll do is cause bronchospasms. If they cause bronchospasms, it means they are not safe for COPD and asthma patients. So if they aren't safe for them, you need to remember two things. Our beta blockers are drugs that end in lol. Also, look at these names. You'll have to memorize them. There's no formula for this, you just have to learn the names. And since these only work on the heart and not the lungs, they're safe for the lungs. So we call these cardioselective. However, some beta blockers work on both. They aren't specific to either, so they'll work equally on both. These are non-selective beta blockers, so we can't give them to patients with COPD or asthma. Now, normally what happens is that medications acting on the heart, whether it's these heart-acting medications, what they do is they block this. This means they block the SA node receptors, so the SA node's activity decreases. Since the SA node's job is to generate the heart rate will decrease. Whenever the heart rate decreases, we measure the heart rate in time. The word for time is chrono. So chrono, and since it decreases it, it's negative. For an action, we use the word tropic. So this becomes negative chronotropic. Additionally, they also block the receptors of the AV node. This means the AV node's function is also reduced, which means conduction is decreased. Conduction is decreased. Now, the word we use for conduction is dromo, so that's dromo, and the word for action is tropic. Since they're decreasing it, it's negative. This means beta blockers are negative dromotropic. Furthermore, these beta blockers block the receptors here on the ventricular wall. Because of that, they won't be stimulated. Without stimulation, the force of ventricular contraction will decrease. And for contractility, the word we use is I know, and if there's an action, it means tropic for that, and to decrease means negative. So we can say that beta blockers are negative chronotropic, negative dromotropic, and negative inotropes. Besides this, we need to remember one more thing. If they decrease the heart rate, it means they'll also decrease the BP. So the formula for BP is heart rate multiplied by systemic vascular resistance multiplied by cardiac output. If the heart rate decreases, then the blood pressure will decrease. Whenever we give a patient a beta blocker, if the heart rate is less than 60 beats, then we must withhold this beta blocker immediately. Because if severe bradycardia occurs, if the bradycardia is very high, then the blood pressure will also drop significantly, leading to severe hypotension. If there's severe hypotension, the patient might later go into shock. So, whenever the heart rate is below 60, withhold this drug. Besides this, we have another medication, like Digoxin, which is a cardiac glycoside. What does it do? It's also negative chronotropic. This question is also asked many times. If the heart rate is less than 60, when giving Digoxin to a patient, you should withhold that Digoxin if it's an adult patient. That was it. Additionally, if the blood pressure drops because of the beta blocker, meaning if the systolic blood pressure is less than 90 millimeters of mercury, then we should withhold it. But we shouldn't give it to patients with COPD and asthma, because in COPD and asthma patients, we can give these medications, these cardioselective ones. But if we give these medications like propranolol, gemalol, and sotalol, it means it'll cause bronchospasm, and the airway will then be obstructed in the patient. So that's what's given in the question. Propranolol is given, which means it's non-selective beta blocker. A client with heart failure is prescribed Digoxin. Digoxin is given, which is a cardiac glycoside, meaning it will decrease the heart rate so that the workload on the heart remains low. Besides this, it increases the force of contraction. It increases the force of contraction of the ventricle. This means increasing the force. For force, we use the word ino, for action, tropic, and for increasing, positive. So it's positive inotropic, but it will be negative chronotropic, meaning it decreases the heart rate. So, which findings should the nurse recognize as an early sign of digoxin toxicity? It's asking about digoxin toxicity because the therapeutic range of digoxin is very narrow. So, whenever digoxin toxicity occurs, the GI and eye systems will be affected first. The GI system will be affected, meaning there will be chances of nausea and vomiting in the patient. Besides this, the patient will have anorexia. Additionally, the patient will have blurred vision and a yellow halo around their vision, meaning whenever there's an object, the patient will see a yellow-colored halo around it. If you see a yellow circle, the patient will have vision and GIT-related symptoms. So look here, hypertension and tachycardia. No, not tachycardia. It lowers the heart rate, so we'll eliminate this option right away. Yellow-green visual halos and nausea. Nausea means it's related to the GI system, and yellow visual halos mean it's eye-related. So early symptoms are related to the eyes and GI. Nausea and vomiting plus vision issues. So this is our answer. Increased appetite and insomnia. See, appetite never increases, it decreases when a patient has digoxin toxicity because the body thinks toxin levels are high, so it tries to flush things out and reduces the appetite, meaning it reduces our appetite so that there isn't any more intake. Polyuria and dry mouth. This is mostly seen with diuretics. A client arrives in the emergency department with chest pain and receives sublingual nitroglycerin. Which statement by the client requires the nurse's immediate intervention? This means we have to choose the incorrect statement, meaning for the patient, chest, meaning the patient has chest pain, and for that chest pain, we've given sublingual nitroglycerin. So whenever we give nitroglycerin to a patient, that nitroglycerin changes into nitric oxide. Nitric oxide is what dilates the blood vessels. So this means whenever nitroglycerin is given to a patient, it will dilate the blood vessels, whether it's the coronary artery or blood vessels anywhere else in our body, like cerebral blood vessels, it dilates them all. Due to dilation, it's possible that if the patient has, say, myocardial infarction or angina pectoris, if the patient has angina pectoris, as soon as the coronary artery dilates, the oxygen supply will increase. Because the oxygen supply increases, the chest pain will decrease if the patient has angina. We have to choose the incorrect statement. I keep my nitroglycerin tablets in the original dark bottle. Yes, they must be kept in a dark bottle because when nitroglycerin comes into contact with air, its potency decreases. That's why it's kept in a dark, airtight container. So this is a correct statement. We need to find the incorrect one. I get a mild throbbing headache after taking this medication. Yes, when a patient takes nitroglycerin, vasodilation can occur, which can cause a headache. This is also a correct statement. I took sildenafil last night. Look, whenever you see fill at the end of any medication, those fill medications are mostly used for erectile dysfunction. And erectile dysfunction medications always cause vasodilation. So when they cause vasodilation, and on the other side, nitroglycerin is also causing vasodilation, there's a chance of severe hypotension in the patient. So this means this medication should not be given to the patient. This is an incorrect statement, so this will be our answer here. I sit down before placing the tablet under my tongue. So whenever this tablet is given to a patient, it means this is a correct statement because the patient understands that when vasodilation occurs, their BP will drop, which could lead to orthostatic hypotension. So this is a correct statement for the patient. Besides this, there's one more thing to keep in mind regarding nitroglycerin. Whenever a patient has angina, we can give a maximum of 3 doses of nitroglycerin, and these are given sublingually. All these doses are given at 5-minute intervals, up to a maximum of 3. After 3 doses, we must not give any more nitroglycerin to the patient. A client with heart failure is prescribed spironolactone. Spironolactone is a diuretic, and it's a potassium-sparing diuretic, meaning it doesn't let potassium be excreted. Which statement by the client requires the nurse's immediate intervention? So whenever a patient is given spironolactone, and they're a heart failure patient, it means we need to reduce fluid and increase urine output. So if spironolactone has been given to the patient, then which of these things is such that the nurse would need to intervene immediately? For this, we need to see what happens when we give spironolactone to the patient. So what will it do? Coming into our kidneys, in the DCT of the nephron and the collecting duct, there are principal cells. On these principal cells, there are some small receptors. It will block these receptors, which we call aldosterone receptors. If it blocks these, then the aldosterone that was being produced won't be able to act on these principal cells. And aldosterone's job is to reabsorb sodium and put it back into the blood vessels. That's aldosterone's job. If sodium goes inside, then sodium won't go out. If it doesn't go out, it means urine output will decrease. But what medication have we given? We've given spironolactone. So as soon as we've given the spironolactone medication, it will block those aldosterone receptors on the principal cells. Once it blocks them, it means that this sodium won't be able to go inside. That is, it won't be able to go from the DCT and collecting ducts into the blood vessels. It won't be able to go, which means it will be excreted from the kidney, and if sodium is excreted from the kidney, it means water will also be excreted, and water excretion is exactly what we wanted for heart failure. But what will happen is that in these principal cells, the exchange of sodium and potassium is opposite to each other. If sodium goes in, then potassium will come into it from the blood vessels. If sodium doesn't go in, then potassium won't come out of the blood vessels. So what happened here is that sodium went out and didn't enter the blood vessels through these principal cells. It didn't enter, which means potassium won't go out now, so potassium will start being retained within the blood vessels. This means the potassium level in the blood vessels will increase, leading to a chance of hyperkalemia. So this means spironolactone is a potassium-sparing diuretic. Therefore, there will be a risk of hyperkalemia in the patient. So now let's solve this question. In a heart failure condition where spironolactone is being given, in which situation does the nurse need to intervene immediately? I eat bananas every morning with breakfast. Now, you have to keep in mind which foods contain potassium. Potassium-rich foods include bananas, avocados, oranges, spinach, tomatoes, potatoes, coconut water, and salt substitutes. So if the patient ate a banana, it means their potassium is already. It's rich in potassium, and if it's potassium-rich, then with spironolactone, the potassium level will increase even more. This means there'll be a risk of hyperkalemia, so this statement is incorrect, making it our correct answer. I avoid canned soup because of the sodium. Yes, canned soup contains sodium and the patient has heart failure. So in a heart failure condition, we shouldn't give sodium because the more sodium we give the body, the more fluid it retains, and the heart failure condition will keep getting worse. I take the medication in the morning. This is also a correct answer because it's a diuretic, and diuretics are mostly given in the morning so that the patient's sleep at night isn't disturbed. This is also a correct statement. I will check my weight every day. Whenever a patient is given a diuretic, or when a patient has heart failure, we should check their weight every single day. This is also a correct statement. A client with newly diagnosed hypertension is prescribed hydrochlorothiazide. Hydrochlorothiazide is a drug in the thiazide category that increases urine output. It also excretes more potassium out of the body. This means sodium, what it does is it increases urine production, and along with that, it also excretes potassium. This means it's a potassium-wasting diuretic, which assessment finding requires the nurse's immediate follow-up. This means when will the nurse perform an immediate intervention? Potassium level of 3 milliequivalents. So the normal level is 3.5 to 5 milliequivalents. This means hyperkalemia. If there's hypokalemia, there's a risk of dysrhythmia in the patient. So we shouldn't let dysrhythmia happen. This means an immediate intervention is needed here. So this will be the correct answer. Increased urine output during the day? Yes, this is an expected effect because we're giving the patient a diuretic, so urine output will increase. Mild increase in the blood glucose level, that is not related to this. And blood pressure of 108, that is a normal reading. And this is slightly low, but with the diuretic, this is expected. A client arrives at the emergency department with crushing chest pain radiating to the left arm. This means the patient might have angina pectoris. The healthcare provider suspects an acute myocardial infarction. This means the patient has a myocardial infarction. And myocardial infarction is a condition where the myocardium in our heart, due to a lack of oxygen, its tissues have started to become damaged. Which medication should the nurse anticipate administering first? So which medication will the nurse give first? So in this, we have to give such a medication. So myocardial infarction means that our heart, and in this heart, if the coronary artery, suppose this coronary artery, a plaque has formed inside it, a fat plaque has formed, which means an atherosclerotic plaque has formed. Now this plaque, when it ruptures, as soon as it ruptures, platelets start to gather here. And when platelets gather, there will be even more obstruction. This means this condition will get even worse, so our main focus should be so that no new blood clots form here. Because if this atherosclerotic plaque ruptures, platelets will quickly arrive at the site and form a clot, which will then block the entire coronary artery. So now our main goal is to give some medication so that even if this plaque ruptures, platelets don't collect here. So if this plaque breaks and a clot starts to form, it won't grow any larger, meaning platelets won't accumulate here. Morphine reduces preload and decreases anxiety. By reducing anxiety, what happens is that in the patient, the heart rate will decrease, which means the workload on the heart will be less. A lower workload means oxygen demand will also decrease. We can give this, but the question asks which one to give first. Besides, morphine also reduces preload, so that means on the heart, the workload will be reduced, so we give it. But we'll see which one to give at the very beginning. After that, nitroglycerin. What nitroglycerin does is it dilates the blood vessels throughout the body, so it will also dilate the coronary blood vessels. If these dilate, oxygen flow will increase. Increased flow means tissue damage will be minimized where oxygen is lacking. But let's see which one to give first. Then there's metoprolol. Metoprolol is a beta blocker, and what it does is it lowers the heart rate. Lowering the heart rate means it reduces the cardiac workload, so it's also beneficial. But aspirin is the medication we'll give first, because aspirin prevents platelets from collecting. It's an antiplatelet medication. This means whenever this plaque ruptures, it won't allow platelets to aggregate or collect. Platelets won't collect, meaning a new clot won't form or an existing clot won't get any bigger. Its size won't increase and more platelets won't be able to gather there. So our primary goal is to give aspirin. Therefore, this will be the correct answer here. After that, we'll give nitroglycerin, then morphine, and finally, once the patient is stable, we'll give metoprolol. For instance, we first gave the patient oxygen. We only give it if the patient has hypoxia. Otherwise, what happens is that as the patient has chest pain but no hypoxia, and you give them oxygen anyway, that oxygen reduces the amount of nitric oxide in our body. Nitric oxide is what dilates our blood vessels, including the coronary arteries. So if the patient isn't hypoxic, meaning they aren't low on oxygen, and you give it anyway, it's possible that in that patient, nitric oxide levels will drop. Lower nitric oxide means no vasodilation. Without vasodilation, the coronary artery might spasm and constrict even further. This could worsen the patient's myocardial infarction or angina. So first, we must check oxygen saturation. If it's low, we give oxygen. If not, we move to the next step and give aspirin. But if saturation is low, we give oxygen first, then aspirin, and after aspirin, we give nitroglycerin, so the coronary artery dilates. After that, we give morphine, so the patient's anxiety decreases, lowering the heart rate or reducing preload to lower cardiac workload. And then we give them these medications, like other supportive medications, like beta blockers. So we can give these medications to them. A client with atrial fibrillation has been taking warfarin for 3 months. Atrial fibrillation means our atria fibrillate, meaning its contraction, which should be in a normal rhythm, is unorganized instead of a fixed speed. It starts quivering very quickly. What happens is that because of that, the patient is given warfarin. Warfarin is given to the patient because if the atria fibrillate quickly, if they fibrillate, then the atria won't be able to push blood into the ventricle well. If blood isn't pushed into the ventricle, it stays stored in the atria. And if blood stays stored anywhere for too long, clots can form. So we give medication to prevent clots. So we gave him warfarin. Which statement by the client requires the nurse's immediate follow-up? Meaning, what does the nurse need to follow up on immediately? So I started drinking the cranberry juice every day. So cranberry juice works just like warfarin. Meaning, what will it do? It means whenever a patient takes cranberry juice with warfarin, the warfarin's effect increases even more. This means the patient could have bleeding anywhere. The patient should have avoided this, but they're taking it, so the nurse needs to follow up immediately. So this is our correct answer, because we have to identify the incorrect statement as it asks for immediate follow-up, right? I use an electric razor when shaving. An electric razor reduces the chances of bleeding. This means whenever we give the patient this, warfarin or heparin, we should use an electric razor. That's a correct statement. I try to take the medication at the same time every evening. Yes, that's fine. That's a good thing. It's a correct statement. I wear shoes when walking outside, meaning nothing will prick the feet so there won't be chances of bleeding. This is also a correct statement. A client with hyperlipidemia is prescribed atorvastatin. Whenever you see statin at the end of a medication, understand it's to lower lipids or cholesterol, like atorvastatin, simvastatin, rosuvastatin. Which statement by the client requires the nurse's immediate follow-up? I started having muscle pain and dark-colored urine. Whenever we give a patient atorvastatin, simvastatin, or we give rosuvastatin, meaning medications that lower cholesterol are given. So what happens in that is that these muscles, the skeletal muscles, it breaks them down. So if skeletal muscles are broken down, then myoglobin will be released from there. And this myoglobin gets stuck in the nephron filters inside the kidney. And if it gets stuck there, the chances of kidney failure will increase. So the first sign of this is, suppose normally, where will this work? Normally, our fat-lowering medications, like the statin medications, work on the liver and reduce cholesterol production through the liver. It has a side effect where it starts damaging the muscles within those skeletal muscles. Whenever it damages the muscles, the patient will have muscle pain. muscle pain, which we call myalgia, so myalgia will be present. And after that, what it does is it damages the skeletal muscles, which causes rhabdomyolysis in the patient. Myolysis. Lysis means breakdown, myo means muscle, and rhabdo means skeletal. This means there is a breakdown of skeletal muscles, so because of that, myoglobin will be formed. Myoglobin is being formed, which means it will then go to the kidney and get stuck there. This means there will be chances of kidney failure. So whenever myalgia occurs in a patient, meaning muscle pain, the doctor must be informed immediately. So now, what will happen? This will be our correct statement. I mean, whenever a patient tells us this, we will need immediate follow-up, because the question asks what will require immediate follow-up, meaning for which thing does the nurse need to intervene? I take the medication in the evening, so this isn't anything specific. They can take it in the evening. It's a correct statement. So, sorry, we don't need follow-up for this either. This isn't a time-specific medication. I am trying to reduce the fried food in my diet. Yes, this is a good thing, because if the patient has hyperlipidemia, then they should make dietary modifications where they take less fried food. So this is a correct statement, so the nurse doesn't need to intervene here. I walk for 30 minutes every day. This is also a good thing. If you want to lower cholesterol, then lifestyle modification is necessary, so the nurse didn't need to intervene in this either. So these were our cardiac medications lectures for today. We'll meet tomorrow in a new lecture. Thank you.